to summarize 10 years of hip arthroscopy stories in 20 minutes, so I'll stay right on time. No problem. My name is Benjamin Domb, here from Chicago. Thank you, Dr. Rath, for having me, Dr. Botzer for inviting me as well. My focus for my whole career in sports medicine has been hip injuries and mainly arthroscopic treatment of those hip injuries. So I hope to share with you some of the evolution of this field that I've been fortunate to be a part of, and some of the things that we've learned along the way. And in the interest of time, I will skip through some slides, but I'll try to give you kind of the important pieces of the story. So it started for me with the question of how can I advance the field of sports medicine, and there have been many giants in the field before me, like that one, who have achieved great things, particularly in sports medicine in the shoulder and the knee. And sports medicine and orthopedics had really been shoulder and knee focused for a long time. So as I grew up in the field of orthopedics and sought for areas where I might make a contribution, the hip jumped out at me as sort of a neglected area and perhaps a unique opportunity, in that it had been an open field for my fellows. Now I tell them, even still, I think there are many job opportunities even in competitive markets for them, and because it's one of the few areas where there's a need in sports medicine. The hip places unique demands on the hip, and those demands depend very much on the sport and differ from one sport to another. You see a butterfly goalie in hockey there. That's a very unique hip motion. And here, Chicago's own Michael Jordan is in a common defensive stance in basketball, and you see that's a very different hip motion. So I began to ask myself the question, why have we not thought of the hip the same way we think of the shoulder or the knee? Twice. I don't know what you saw the first time. So I think the hip and the shoulder certainly do have some commonalities. Obviously they have some differences, but the shoulder was so much further along in sports medicine, and in the shoulder we had always talked about striving to restore anatomy. Same thing in the knee. So when we thought about labral repairs or anatomic rotator cuff repairs, we were thinking of how can we restore normal anatomy. And in the hip, pain had traditionally been diagnosed as early arthritis, and really patients had been offered the advice, you'll eventually need a total hip replacement, not much else we can do for you. And this is a typical patient response to that advice. So hip arthroscopy for me was the ugly stepchild of sports medicine. It was maybe where the knee was in the 70s and where the shoulder was in the 80s, but I think some of us saw there was an opportunity to do surgery for problems that were previously undiagnosed or untreated, maybe to delay or prevent hip replacements, and clearly a field filled with unsolved mysteries. This is a chart of the number of publications on femoroacetabular impingement over time, and you can see this exponential growth in the literature, which I think parallels our understanding as it has proceeded. Again, I'll go through a few things in this talk in the interest of time. I'll skip through the assessment. I'll tell you a little bit about two journeys that I've been a part of, talk about what is treatable today, and maybe a little on where we headed. So the only thing I will give you an assessment, 60% of athletes undergoing an arthroscopy were initially misdiagnosed in Tom Bird's study, and they stayed misdiagnosed for an average of 7 months, which is pretty staggering. And in another study, Closey's study, surgery on the wrong site had been recommended in 17% of patients. So this is somebody who has a hip problem, and instead of seeing Dr. Rath, they see a spine surgeon, and they get diagnosed as having a spinal radiculopathy. Maybe MRI shows a herniated disc, and they get a spine surgery. And actually the problem was the hip all along. I've seen patients have open abdominal surgeries for endometriosis they thought was causing the pain. I saw a man who presented to a urologist with pain here, and the urologist did a spermatic cord nerve stripping. It it was a hip problem all along. I don't even know what that is, this spermatic cord neurostripping, but I don't want to have it if I have a hip problem. So, you know, our brains don't do a very good job of localizing the pain, so it makes it hard to diagnose, and people with hip problems get misdiagnosed with any number of these things. As we go through the assessment, I try to ask myself, is the pain from the hip or something else? Is it intra-articular or is it extra-articular? And if it is intra-articular, can the problem area of the hip be localized by exam? One of my mentors, Frank Jobe, said the diagnostic gold standard is still the history and physical. The MRI helps convince the patient, not the physician, that there's a significant injury. Interesting food for thought. But 10 years ago, we were just figuring out the physical exam. And the physical exam is uniquely challenging in the hip. I think it's a deeper joint, and there are 27 muscles that cross the hip, and there are a lot of other things around it. That's not how you do a physical examination. I'm not going to teach you how to do it today, nor to assess the x-rays, but suffice it to say that all of these things that we know very well now, measurements of x-rays and physical exam tests, were not very well established 10 years ago, and I think Plato said, the eye see only what the mind knows. This picture means more to Midwesterners in the United States than a lot of hunters. If you're not looking in the right place, you won't find what you're looking for. So I think the diagnosis is critical, and there are a lot of physical therapists in the room. You're extremely important in the diagnosis of this stuff, because so many of our patients see you first, and they may spend a lot of time with you, sometimes sent to you with a diagnosis that's not the real diagnosis. So you have an opportunity as physical therapists to steer patients on the right track. The first journey I wanted to tell you about was labral repair, we learned, thanks to Gans and others who did biomechanics studies, that the labrum regulates fluid lubrication. It plays a role in joint stability, acts as a suction seal of the hip joint, and plays a role in load bearing. But we also learned that the labrum sealing mechanisms are dependent on the fit of the labrum against the femoral head. So early in the days of labral repair, some of the labral repairs were technically challenging, and it was hard to get the stitches placed perfectly. And so sometimes our repairs left the labrum everted or bunched. Perhaps this disrupted the contact with the femoral head, and that would then disrupt the suction seal. So we tried to work on various ways of producing an anatomic labral repair with a labral base stitch or labral base refixation technique initially, and subsequently with a variety of other techniques, all aimed at restoring this transitional zone between the cartilage and the labrum and restoring the suction seal of the labrum against the femoral head. So some of the first techniques we worked out for this were called labral base refixation, where we pass the suture either once or twice through the base of the labrum, we published this a long time back now, and it generated quite a lot of conversation in the field. This is a picture of an arthroscopic view of a labral base refixation, and what you can see is the labrum is sealing against the femoral head throughout. So this is the arthroscopic view that I want to see at the end, where I see the labrum has a good seal. Labral reconstruction has evolved more recently, really in the last 5 years, and we found that there are patients who have segmental loss of labrum. The labrum is not repairable. Either it's calcified or it's too shredded, or in revision surgery after there's been a previous failed labral repair or labral excision. In these cases, we can use an autograft or an allograft or an IT band graft, and we can
hamstring tendon
do without
the semitendinosus autograft.
The volume. This is a graft being introduced in a joint. This is a video from probably close to 5 years ago that Dr. Botzer actually produced while you were in Chicago or after. Basically, we reconstruct the labrum with this graft, and we can fill in the defect where there was missing labrum or failed previous labral repair. The second journey I wanted to share with you was that of hip instability, and I would put up this slide. Wait a second, I thought the hip was an inherently stable joint. This is what I was taught when I was in medical school. And it is stable compared to the shoulder, where you have dislocations frequently as a part of sports. Hip dislocations are much more rare. But what we realized is that hip instability does in fact exist, but it's different from the shoulder. It's not dislocations as much as it's micro instability. Instead of being traumatic, it's more chronic. Instead of being acquired, it's often partly congenital. And instead of being dynamic, like with a movement of the shoulder, it's a static thing with weight bearing and loading and unloading the joint. So when we were thinking of instability as a concept, we did this study when Itamar was with us looking at ligamentum teres tears. And the thought was, if microinstability exists, if there is microsubluxation, then it would put traction on the ligamentum teres. So then people with less bony stability should have more ligamentum teres tears. And we found exactly that people with less coverage of the acetabulum had higher incidences of ligamentum teres tears. So it didn't prove that instability exists, but it certainly was consistent with it. And I think this was one of the pieces of evidence that went into the thinking and the realization that instability in the hip does indeed exist. Add to that the understanding of the anatomy and the biomechanical importance of the iliofemoral ligament that came from studies like this one from Mark Safran, and biomechanical studies from Hal Martin and Mark Philippon, and we started to understand that instability exists. Then we had to work out the diagnosis and the surgical indications, which was hard, but we developed physical exam tests like the supine apprehension test and the anterior instability test, and also came to understand better how to assess the bony stability, both on the acetabular and the femoral side. Then we developed the surgical technique for capsular plication with an inferior shift. And the idea was to use our capsulotomy to tighten the capsule and to perform a shift by placing the sutures in an oblique fashion, which would shift the iliofemoral ligament superiorly, like so. And then, of course, once we develop any new technique, we have to prove its outcomes and follow the outcomes. So we did that in patients with borderline dysplasia and a labral tear. And this is a population that previously had not done well with hip arthroscopy. So we treated them with labral repairs and a capsular plication and found that we could indeed achieve favorable results. So I think I have a couple minutes left. In terms of what is treatable today, I think FAI is one of our bread and butter diagnoses, femoroacetabular impingement. Pincer type, where there's overhang of the acetabular rim, and cam type, where there's asphericity of the femoral head. The goal, I think, is to create normal version of the acetabulum when we treat pincer impingement, and to create a spherical femoral head when we treat the cam lesion, either open, like you see here, or arthroscopic, like you see here. The arthroscopic perspective alone may be insufficient to do that. It's sort of like looking at the earth from this view of the beach. You can't see that the earth is round from the arthroscopic perspective, same thing of the femoral head. But when we look with x-ray, it's like we're looking at the earth from the moon. We see the whole globe, and we can see what's round and what needs to be resected to make it round. So there's pre and post-op. I did want to briefly mention, because this talk was titled our 10-year experience, this was a study on which Mark Hutchinson is a co-author, where we looked at a large series, 1,038 patients, which was the largest series we had done as yet in the outcomes literature. And I think this study made a contribution to the field because of its size, its numbers, its sample size, and also because of the heterogeneity of the group, which is both a strength and a weakness. But with this sample size, it allowed us to break things down, looking at revisions versus primary hip arthroscopies. We found an overall conversion rate in the primary hip arthroscopy setting of 5.6% over a minimum of 2-year follow-up, and the relative risk of a total hip after a revision procedure was more than twice that. Overall complication rate was in the acceptable zone, 4.3%, mostly minor complications. And now we're at the midterm. So our midterm studies are starting to be published now at our 5 and 10-year follow-up, which I think will continue to provide more information for the field, both about what works and what doesn't work, and what we can tell our patients to expect in terms of progression of arthritis over time. I'll skip through gluteus medius tears, another favorite diagnosis of mine, and conclude with where are we headed. You know, if we go back to the shoulder and think back to the evolution of understanding, in the 1960s, Neer described impingement in the shoulder. And my understanding from my mentors is that for about a decade, everybody with a shoulder problem was diagnosed as having impingement. And then some smart surgeons realized that some findings didn't fit, and that led to the discovery of all these other problems, which we now know so well in the shoulder. So in the hip, in 1999, we thought that labral tears were a watershed vascular problem. And then in 2001, Gans described FAI. We realized that's probably a much more common reason. But for a decade there, everything in the hip was impingement. And I think some smart surgeons have realized that some findings don't fit. And here we are again, following the same roadmap. So we have to seek to explain these other findings and find all the other reasons why the hip is a problem. That's my son, and you know, when I see him in this outfit, or see some of our fellows or medical students come through, I'm reminded that fresh eyes see new things, and I always listen to my fellows and listen to my medical students and even my college students who come visit, because sometimes the things that I have gotten so used to, I forget I'm seeing. And when fresh eyes come in, they may come in and look and see, gosh, you know, how come you do it that way? There's an easier way. And I've been doing it that way for 10 years, and I forgot to even think about it. So I always listen to the new people who work with us, and we get a lot of valuable information from them. And questions I think we want to ask: how much arthritis is too much? What to do if a hip arthroscopy fails? And how can we make this procedure easier? Because it is still a very technically difficult surgery. So I think that I hope that part of my contribution to the field over time will be helping to shorten the learning curve to make this procedure available to more surgeons and to more patients. So to wrap up, hip preservation is a new field. The concepts are challenging, the surgery is challenging. There are educational resources available. The American Hip Institute has an educational website for surgeons which contains video and publications. It's a field which has undergone a fascinating evolution of understanding, and I think gives us all the opportunity to help people who may otherwise not have been helped. So thank you very much. Once again, it's great to be here.